Assalamualaikum and a good day to Madam Harina and our audience. Today we would like to present to you a topic under MRD515 entitled as urinary system with renal cell carcinoma. So this is the member of the group that consists of the first one is AZMINA binti Muhammad REPIN, and the second one is MUSFIRAH ARIFIN binti MUSTAZZA, and the last person will be FARAH NAFISAH AYUNI binti Muhammad SHAHID.
So let's begin to the presentation with the introduction. So you guys may wonder, what is renal cell carcinoma? Renal cell carcinoma, or known as RCC, is the most common malignant renal neoplasm worldwide. It originates from the epithelial cell of the renal tubules. And RCC is not a single disease, but it is a heterogeneous group of tumor, meaning it has different of histological subtype, molecular alteration, clinical behavior, and also prognosis. And among all of these subtypes, clear cell renal cell carcinoma is the most common subtype, where it accounted about 75 to 80% for all cases. And globally, there were an estimated 434,840 of new RCC cases in 2022. Is showing that this disease actually continue to be grow and become a very health burden to worldwide. Next, I will explain the etiology or causes of renal cell carcinoma. The first one, we have smoking, because long-term smoking can actually increase the risk of RCC about 50%, mainly due to carcinogenic substance that cause the DNA damage in tubular cells. And second is obesity. Around 30% of RCC cases is actually linked to obesity. This happens because due to hormonal changes, insulin resistance, and chronic inflammation that actually can promote tumor to be growth. And the third one is genetic factor. Approximately 90% of cases of VHL tumor suppressors genes is common in clear cell RCC. And lastly is hereditary syndrome. Because hereditary syndrome also can contribute to RCC development because it includes von Hippel-Lindau disease, BAP1 tumor predisposition syndrome, and also hereditary leiomyomatosis with renal cell carcinoma, also known as HLRCC. So moving on to the complication of renal cell carcinoma. One of the major complications of RCC is metastasis. RCC is commonly spread to the lung, bones, liver, and also brain, which can lead to respiratory problem, bone fracture, and also neurological deficit. And another complication that involve renal problems such as hydronephrosis, reduce of glomerular filtration rate, and progression to chronic kidney disease or renal failure. And RCC can also cause paraneoplastic syndrome, which occur even without metastasis. Example like hypercalcemia, erythrocytosis, and also non-metastatic hypertension.
Now let's move to the imaging modalities used in renal cell carcinoma evaluation. The first modality is contrast-enhanced computed tomography, or known as CECT. CECT offers an excellent visualization of renal anatomy and tumor enhancement patterns. Next, it provides a comprehensive disease staging in a single examination, which improves the diagnostic accuracy. CECT also has higher sensitivity in detecting malignant renal masses, which are able to differentiate between solid malignant tumors and benign cystic lesions. Furthermore, it offers rapid image acquisition, which is particularly useful in trauma or emergency cases. Even so, CECT is contraindicated in patients with renal impairment or contrast allergy. Although CECT has high sensitivity, but it has relatively low specificity compared to MRI, which may lead to false positive findings. It also uses ionizing radiation, which is generally avoided in pregnant patients due to radiation. It also gives a relatively higher radiation dose, and it increases the dose to the patient if repeated examination is required. The next modality is magnetic resonance imaging, or known as MRI. MRI does not use ionizing radiation, which is safe for repeated examination and suitable for sensitive patients. Next, it is useful for contraindicated patients who are allergic to iodinated CT contrast and pregnant patients without renal failure. It also has high specificity with comparable sensitivity to CECT. MRI also provides a superior soft tissue contrast, which offers excellent in characterizing renal lesions and distinguishing benign masses or complex cysts. In addition, the diffusion-weighted imaging DWI in MRI also aids in assessing small or indeterminate renal lesions. However, MRI provides a longer image acquisition time, which can cause motion artifacts due to the patient movement or breathing. Next, MRI is also more expensive and has limited accessibility compared to the CT. The last modality is contrast-enhanced ultrasound, or known as CEUS. CEUS also does not use ionizing radiation, which is safe for repeated examination and for pregnant patients. It is also useful for patients with renal impairment or contrast allergy. CEUS also provides a comparable lesion characterization in selected cases, which it is more sensitive than CT in differentiating solid components within the cystic masses and detects the wall or septa thickening, which may indicate malignancy. Additionally, CEUS is highly effective in characterizing indeterminate renal masses, complex cystic lesions, and renal pseudotumors from malignant tumors. However, CEUS is unable to provide a comprehensive staging as CT, as it is an operator-dependent modality and only allows one renal lesion to be evaluated at a time. On top of that, the diagnostic performance is also reduced in deep-seated renal tumors, especially in the obese patients.
Next, we will be looking on the radiological appearance of the renal cell carcinoma.
Let's start with the first imaging modalities, which is the contrast-enhanced CT. So this is an example of CT image of renal mass. So first, take a look at image A. Image A demonstrates a large mass in the right kidney. Prominent peritumoral vessels are seen, that is shown by the white arrows, and the lesion shows heterogeneous enhancement, which is attributed to the presence of necrotic areas within the mass. Next, we will take a look at the image B. Image B also shows a large heterogeneous exophytic renal mass arising from the middle pole of the right kidney. There are prominent peritumoral vessels visible, which is shown by the black arrows. So similar to image A, the mass demonstrates heterogeneous enhancement due to the internal sclerosis. The next one is the MRI. This is an example of MRI image of renal mass. First, we will take a look at the image A. Image A shows a heterogeneous hyperintense tumor in the left kidney on axial T2 weighted image. So, just like indicated by the arrows. The next one is the image B. Image B also demonstrates the same tumor on contrast-enhanced PET suppressed axial T1 weighted imaging during the corticomedullary phase. At the arrow, the lesion shows heterogeneous enhancement. The next one is the image C. Image C is an in-phase MR image where the tumor appears iso-intense, just like the arrow indicates. While image D is the corresponding out-of-phase image that shows a focal signal intensity drop within the tumor, which is indicated by the arrow, suggesting intracellular fat or other tissue characteristics. Finally, we have the contrast-enhanced ultrasound. The first one is the image A, which is the corticomedullary phase that shows a heterogeneously hyper-enhancing mass that arises exophytically from the right kidney, just like the arrow indicates. Whereas the image B is the delayed phase that demonstrates the washout of the mass, that indicating a reduction in enhancement compared to the earlier phase.
Next, we will be moving on to the technical consideration of the renal cell carcinoma procedure.
So, before we perform a contrast-enhanced CT procedure, renal function screening must be carried out to ensure the patient's safety. Intravenous contrast agents are contraindicated in patients with blood urea nitrogen levels greater than 15 mg deciliters or serum creatinine levels greater than 3 mg deciliters. The estimated glomerular filtration rate or eGFR should be greater than or equal to 90 mm per minute per 1.73 square meters. So, for patients with an eGFR less than or equal to 30 millimeters per minute per 1.73 square meters, contrast-enhanced CT should be avoided due to the risk of permanent renal damage. In these cases, alternative imaging modalities such as non-contrast MRI or contrast-enhanced ultrasound are recommended. In contrast-enhanced CT of the kidney, specific technical parameters must be followed according to the renal mass protocol. The slice thickness should be set at less than or equals to 3 millimeters, and multiplanary formatted images should be obtained to accurately evaluate for capsular breach. The next technical consideration is about the contrast-enhanced CT imaging phases and interpretation. First, during the pre-contrast phase, enhancement is confirmed when there is an attenuation increase of 20 Hz per unit or more after the contrast injection. Additionally, the presence of macroscopic fat measuring less than or equal to 10 Hz per unit suggests a benign angiomyolipoma. Next, the corticomedullary phase, which is performed at 30 to 40 seconds after the injection. This is particularly useful for highlighting the clear cell renal cell carcinoma due to its intense arterial enhancement. This phase also allows assessment of renal vein and venous extension. And finally, the nephrographic phase, which is acquired at around 100 and 120 seconds, which is important for detecting small, hypoenhancing endophytic renal masses. This phase provides a uniform renal parenchymal background, which improves lesion conspicuity.
The appropriate imaging modality for renal cell carcinoma evaluation is contrast-enhanced computed tomography. CECT is considered the gold standard in assessing renal cell carcinoma as it provides a comprehensive staging ability in a single examination, highly sensitive for characterizing and detecting renal lesions, offers rapid image acquisition, provides an excellent visualization of renal anatomy and tumor enhancement patterns, capable of differentiating between solid malignant tumors and benign cystic lesions. Furthermore, MRI and CEUS serves as valuable complementary modalities, especially for fluid lesion characterization and in selected patients. Last but not least, imaging findings should be correlated with histopathological examination from biopsy, which remains the definitive method for malignancy confirmation and treatment planning.
So, in conclusion, renal cell carcinoma or RCC is a common malignant kidney tumor where the diagnosis and treatment planning depend on the cause and consequences because the disease can actually spread and impact the patient quality life. In addition, contrast-enhanced CT remain as the primary imaging modalities, while CUS and MRI serve as complementary modalities for this disease. Lastly, to guarantee patient safety and comfort, choosing appropriate contrast and following the proper imaging protocol must be taken as technical consideration. That's all from me.
So that's all from us. Here is our list of reference that we use throughout this presentation. Thank you for watching.